Thank you very much for a kind introduction. Good afternoon. Salemo Aleko. My name is Martin Haluzik. I'm from Diabetes Center, Institute for Clinical and Experimental Medicine in Prague, and it's my great pleasure to be with you today, although just virtually, and I would certainly love to come rather in person, but it's obviously difficult nowadays in these COVID times. In any case, I'm very glad I can share with you the presentation entitled Introducing Iglarlixi Soliqua Clinical Data. These are my disclosures, and this is the agenda of my talk. I will just briefly start by unmet medical needs in type 2 diabetes treatment intensification, and I'm sure in Egypt you face very similar problems as we do in the Czech Republic and in Europe. And then I will move into the introduction of fixed ratio combinations and its position in ADA-EASD consensus. Then I would like to briefly summarize for you the Lixilan program, which is a program that studied a fixed ratio combination of insulin glargine and GLP-1 receptor agonist lixisenatide. And then I will just very briefly summarize for you the differences between sequential versus simultaneous addition of long-acting insulin and GLP-1 receptor agonists. And I will end up my presentation with some practical aspects of Soliqua initiation. So let me start with the unmet medical needs in type 2 diabetes treatment intensification. So I think you would agree with me that despite new therapies, many people with type 2 diabetes are still not at goal. And there remains a high unmet need worldwide for further therapeutic intensification. So for example, in the United States, you can see that more than 50% of adult patients with type 2 diabetes are not at target, meaning glycated hemoglobin below 7%. And as you can see in Europe, we have very similar data. And in fact, if you look at the right side of this slide, you can see that if the patients are treated by oral glucose-lowering agents only, they still only have like 40% chance to be on target. And if you take the patients who are on the combination of oral anti-diabetic agents with insulin or insulin alone, you can see that only about 20% of these patients are within this goal. So there is huge unmet need for patients with type 2 diabetes to achieve optimal glucose control. Now, many patients continue to struggle with particularly high HbA1c, and these are again American data, and you can see the differences throughout the years, starting from 1999 to 2014. And you can see that there is still a high percentage of patients, about 20% of patients had HbA1c above 9% these 20 years ago, and it didn't get much better in 2014, still about 16% of patients being that high. And if you look at the patients with HbA1c above 8, more than 32% was above 8 in around 2000. And there is still about 28% of patients with HbA1c above 8 in 2014. And again, if you look at the percentage of patients within different HbA1c levels, you can see that there is about 27% of patients with HbA1c higher than 9%, and about 24% of patients with HbA1c between 8 and 9%. And the proportion of patients with HbA1c over 9% was highest in Southeast Asia and Eastern Mediterranean region. And in fact, in total, 19 countries had more than 25% of patients with HbA1c over 9% at initiation of second-line therapy in patients with type 2 diabetes. So it's a major problem. Now, why is achieving glycemic control so challenging? Well, there are many reasons, obviously, and I'm sure you as experienced endocrinologists know them. So type 2 diabetes is a heterogeneous multifactorial disease, and there are many organs and many pathophysiological mechanisms contributing to hyperglycemia. Its insulin resistance is decreased insulin secretion, but there is also an important contribution of kidney by glucose reabsorption. There is a contribution of intestine by producing the incretin hormones, contribution of brain, adipose tissue, and many others. And therefore, multiple therapies are needed that target different pathophysiologic abnormalities. So really only few patients can be optimally controlled when on the monotherapy with one glucose-lowering agent. Furthermore, we all know that beta cell impairment and loss begins very early in the course of type 2 diabetes and correlates with HbA1c. So here you can see a slow decrease in beta cell function even before the diagnosis of type 2 diabetes. And then if you look to the right side, you can see that there is a very straightforward relationship of HbA1c and beta cell function in newly diagnosed drug-naive patients with type 2 diabetes. And you can see that approximately 62% loss of beta cell function is present in patients with HbA1c above 9%, meaning that there is a close correlation with baseline HbA1c at the time of diagnosis and the beta cell reduction. Finally, if we have the patient who is on the oral anti-diabetic agent, on the monotherapy, and we add either single injection or the second oral anti-diabetic agent, it is still not enough in most of cases to achieve appropriate glucose control and to get patients to the goal. So this is just one piece of data, and I'm sure you can find some different numbers from different trials. But just to make the long story short, even if you put this patient on basal insulin, who is not optimally controlled on monotherapy, only around 67% of patients will actually achieve the goal. Only about 50% of patients will achieve this goal when you add second oral anti-diabetic agent. And if you add GLP-1 receptor agonist, you can get close to 60, perhaps a bit more, percent of patients with these most potent GLP-1 receptor agonists. But still, in many patients, you are not achieving the goal with a single injectable. And furthermore, if you have the patient who is already on basal insulin, and I have learned that basal insulin is not like the most often way of initiation of insulin therapy in Egypt, but it is the most common way how we initiate insulin therapy in the Czech Republic. Nevertheless, when you have suboptimally controlled patient on this long-acting basal insulin monotherapy, there are many common barriers to insulin intensification, such as regimen complexity, weight gain, hypoglycemia, reduced quality of life, lack of education and training, and obviously there is a need to do glucose self-monitoring, which is very burdensome for many patients. So again, despite guidelines, there is a failure to initiate or intensify therapy when therapeutic goals are not reached. Now let me move to the fixed ratio combinations and its position in American Diabetes Association, European Association for the Study of Diabetes consensus, because fixed ratio combinations represent a very potent way how to overcome all of these hurdles towards intensification of the therapy. So let me just introduce to you a fixed ratio combination of insulin glargine 100, which I'm sure you know very well, and GLP-1 receptor agonist lixisenatide. So insulin glargine 100 is a gold standard in the insulin therapy. Nowadays, it's most frequently used insulin worldwide. And I'm sure you have a lot of experience with it as well. And you know that the basal insulin primarily reduces fasting blood glucose by targeting hepatic glucose overproduction. And with the one injection per day, you can nicely titrate to target fasting blood glucose, but the postprandial will not be fully improved by this titration. On the other hand, you have lixisenatide, which is a GLP-1 receptor agonist that very nicely reduces postprandial blood glucose because of the significant suppression of glucagon secretion, delayed gastric emptying, and obviously also a glucose-dependent insulin release. And I can tell you that lixisenatide is probably the most potent drug to decrease postprandial blood glucose, the most potent non-insulin drug. It has a very significant effect. Now, so if we want to just define what the fixed ratio combinations are, so the general definition basically says that fixed ratio combinations is a co-administration of 2 or more antihyperglycemic therapies with the same or within the same injection, and then they can be adjusted through titration. And importantly, components should exhibit complementary actions that allow for improved glycemic control versus individual components alone. And I think this is exactly the case for the combination of insulin glargine and lixisenatide. And they may also be associated with reduced side effects versus individual components alone. And I will show you later on that this is also the case for this fixed ratio combination of insulin glargine and lixisenatide. And obviously, these fixed ratio combinations have a very important position in the 2020 American Diabetes Association guidelines, which state that combination of basal insulin and GLP-1 receptor agonist has potent glucose-lowering actions compared with intensified insulin regimens. And 2020 American Association of Clinical Endocrinologists and ADA 2020 recommend early combination therapy in patients with HbA1c over 9% or 1.5 to 2% above target. And very importantly, if you have a patient who is either on long-acting insulin alone or GLP-1 receptor agonist alone, then fixed ratio combination is a perfect way how to intensify the therapy. So to make the long story short, there are many places where you can use very successfully fixed ratio combination of long-acting insulin and GLP-1 receptor agonists. Now let me move to the Lixiland program. There are 2 pivotal clinical trials that I will just briefly walk you through. The first one is called Lixiland-O clinical study. And this study enrolled patients who were treated by 1 or 2 oral antidiabetic agents, one of them being metformin, and were suboptimally controlled at the beginning. And after enrollment, there was a metformin titration phase, a run-in period where metformin was titrated to at least 2,000 milligrams per day or maximum tolerated dose, and other glucose-lowering agent was discontinued at this period. And then the patient, you can see that there was very little change in HbA1c after that titration, and then the patients were randomized into 3 arms: insulin glargine alone, lixisenatide alone, or insulin glargine lixisenatide fixed ratio combination. And then the primary endpoint was a change in HbA1c from baseline to week 30. And another important thing to mention was that the maximum allowable insulin glargine dose was 60 units for both Iglarlixi lixisenatide and insulin glargine treatment groups. So let me move to the primary endpoint result. And as you can see, there was a decrease from the baseline HbA1c 8.1 to 6.5 in patients treated with a fixed ratio combination of glargine lixisenatide. And 6.5, I think, to many of us, this is really amazing achievement. With very few, if any, other therapies, you can achieve such a significant decrease. And importantly, with insulin glargine alone or with lixisenatide alone, significantly lower significantly lower decrease in HbA1c has been seen here, and 74% of patients reached target HbA1c of HbA1c below 7 with glargine lixisenatide fixed ratio combination. These are the changes in body weight during the trial, and you can see that even with having insulin on board, when it was in combination with lixisenatide in Iglarlixi fixed ratio combination, there was still a decrease in the body weight as compared to insulin glargine alone. And there was even more decrease in the lixisenatide alone arm, as you would have expected. Now let's just look at the post-hoc analysis of this trial, looking into the efficacy of Iglarlixi in patients who had HbA1c above 9% at baseline as compared to the overall number of, to the total group of patients, to the entire number of patients. And as you can see here, the efficacy obviously was much higher in the patients with higher baseline HbA1c, again, something you would have expected. But look at the decrease here, 2.9% decrease with the Iglarlixi fixed ratio combination. So I think, again, this is another reason why in patients with very poor glucose control, we should consider starting with fixed ratio combination rather than insulin or GLP-1 receptor agonist alone. And this is the percentage of patients reaching the target HbA1c. And you can see that in all patients, with baseline HbA1c above 9%, or with patients with 2 oral antidiabetic agents at screening, in all cases, glargine lixisenatide was most efficacious. And you can see that comparable percentage of patients, over 70, was actually reaching the goal. And this is a very commonly used composite endpoint of percentage of patients reaching HbA1c below 7 at week 30 without hypoglycemia. And again, you can see that over 50% of patients have reached this goal with a fixed ratio combination of glargine lixisenatide, significantly less so with insulin glargine alone or lixisenatide alone. Now let me move to another pivotal trial, which was Lixilan-L. These were the patients with type 2 diabetes uncontrolled on basal insulin plus oral antidiabetic agents. So at screening, during the run-in phase, the patients were put all on insulin glargine, which was titrated. And you can see that HbA1c actually improved after run-in phase from 8.5 to 8.1. And then the patients were randomized either to insulin glargine alone that was further titrated or glargine lixisenatide fixed ratio combination. Again, the dose of insulin glargine was kept at 60 units per day in both arms because that's the maximum dose you can use in the glargine lixisenatide fixed ratio combination. And then the primary endpoint was HbA1c at the end of the trial after 30 weeks of trial. And you can see here that with the fixed ratio combination of glargine lixisenatide, the end HbA1c was 6.9% as compared to 7.5% in the group treated by insulin glargine alone. So quite significant difference. And again, I think this is a great achievement for patients who already have been on insulin therapy. This is the change in body weight, and you can see with glargine lixisenatide there was a significant decrease while there was an increase with insulin glargine alone. And this is the percentage of patients achieving, again, this composite endpoint of HbA1c below 7% without hypoglycemia. 32% of patients on glargine lixisenatide achieving this goal as compared to insulin glargine alone. So again, I would say very important and very impressive data from my point of view. Now let me just briefly discuss the question of sequential versus simultaneous addition of long-acting insulin and GLP-1 receptor agonists, because basically what you can do is when you have patient on basal insulin, you can also add as a second injection GLP-1 receptor agonist. And there are no really direct comparisons available for this approach. So Professor Rosenstock and colleagues have done a propensity score matched analysis, and they have used some previous trials, Lixlan-O, Lixlan-L, and GET-GOAL duo trials to look into the indirect comparison of simultaneous versus sequential administration of long-acting insulin and GLP-1 receptor agonists. So first they looked into the changes in HbA1c, you can see it here, and you can see that with the simultaneous administration there was more profound decrease in HbA1c with glargine lixisenatide in one injection. You can see here comparison of different trials. And if you look at the percentage of patients reaching HbA1c below 7, you can see that it was significantly higher for, again, simultaneous administration, meaning glargine lixisenatide fixed ratio combination. These are the changes in body weight and insulin dose. And again, body weight decreased more significantly in the simultaneous fixed ratio combination of glargine lixisenatide, and much lower insulin dose was actually needed, 21 units or 44 units, as compared to much higher doses with the addition of insulin glargine GLP-1 receptor agonist sequentially. So again, it's I think another very important evidence that it makes sense to use fixed ratio combination in this case. Now, let me just briefly move to the practical aspects of Soliqua administration. First of all, the side effects, and as with any GLP-1 receptor agonist, you have some gastrointestinal side effects, nausea, vomiting, and diarrhea. But if you look at the percentage of patients having these side effects with lixisenatide alone versus fixed ratio combination, you can see that Iglarlixi has in fact less side effects than lixisenatide alone, which is due to slower titration of Iglarlixi fixed ratio combination. And obviously, hypoglycemia, as with any insulin therapy, is present. Nevertheless, there is no significant difference between insulin glargine alone and fixed ratio combination of glargine lixisenatide if titrated properly. So hypoglycemia is not a problem. You can see that severe hypoglycemia was basically non-existent within these trials, and even from my clinical experience, it's very rare. Now, you have two pens to use glargine lixisenatide fixed ratio combination. It's SoloStar prefilled pen. One has 30 to 60 units titration possibility, and another one, the yellow pen, has 10 to 40 units. And there are the differences in ratio of insulin to lixisenatide. So with this pen, you have more lixisenatide per insulin unit. Here you have less lixisenatide per insulin unit. And to make the long story short, for insulin naive patients, it makes sense to start with this pen, 10 to 40, with a higher percentage of lixisenatide. And the initial dose, usually I would start with 10 or 15 units and titrate. And with the maximum dose of 40 units, you will also get the maximum dose of lixisenatide, 20 milligrams. For patients transitioning from basal insulin, the initial dose usually is about 20 units or 30 units, depending on what was the dose of basal insulin. And if you expect that you will have to titrate the patients to higher insulin doses than 40 units per day, then you can prescribe the pen with the higher upper limit of titration, which is this, where you can titrate from 30 to 60 units. And again, the initial dose, 20 to 30 units per day, and then you titrate in a similar way as in a basal insulin. by 2 to 4 units until target fasting plasma glucose is reached. It's very easy, and basically it's intensification without intensification, because you still only, or patient only uses 1 pen and 1 injection per day. With that, ladies and gentlemen, let me summarize that despite advances in therapy for type 2 diabetes, many people with type 2 diabetes are still not achieving their glycemic goals, and we are certainly trying to use personalized medicine and early intensification that should be very easy for our patients. And I do believe that simultaneous therapeutic intensification with fixed ratio combinations like Iglarlixi is more likely to get patients to goal than stepwise initiation of basal insulin followed by GLP-1 receptor agonists, while maintaining the simplicity of a once daily administration. And with that, and with the picture of my home city, Prague, I would like to thank you very much for invitation, and thank you very much for your attention. Shukran.
Thank you, Professor Martin, for this informative and elegant presentation. And unfortunately, because we are out of time, only one short question from the attendees.
This combination will omit two pathophysiological mechanisms in type 2 diabetes, namely insulin resistance and the role of the kidney. What is your opinion?
Hello, I hope you can hear me. Good afternoon, Salamu alaikum. Many thanks for very interesting and very relevant question. So this fixed ratio combination is not meant to replace other treatments for type 2 diabetes. So I think all of the patients who don't have contraindications should be treated by metformin at the same time to influence insulin resistance. And obviously, combining this fixed ratio combination with SGLT2 inhibitors would also make sense from the pathophysiological point of view, but I'm afraid here we may have troubles with reimbursement in many countries. But I do agree with you that if we combine this with metformin, with SGLT2 inhibitor, the efficacy might be certainly even better. And I think in the future we will do that.
Yes. Professor Martin, I have a question for you. Can you hear me?
Yes, I can hear you.
Thank you very much for your nice lecture. I would like to ask, from the pharmacodynamics of lexizanatide, we know that the maximum benefit on postprandial hyperglycemia is obtained after the first meals following the injection. In the meantime, it is written in the prescription information or prescribed information that it is given before the first meal of the day, within 1 hour before the first meal of the day. So my question is, why don't we inject Soliqua before the main meal instead of the first meal in order to obtain the maximum beneficial effect on postprandial hyperglycemia? This is my question.
Yeah, that's a great question, and I don't think that you cannot do that. I mean, if the main meal of the day, for example, is the dinner, I don't think that it's not possible to inject before the dinner. The reason is that it's not only one meal that is very nicely affected, the postprandial glucose, but it's basically 2 meals. So for example, if you inject in the morning, you will see a very nice decrease in postprandial blood glucose after the breakfast and also after the lunch. So it makes more sense to inject it earlier in the day so that you have 2 meals affected, not only one. But if the patient doesn't eat too much during the day, and then, for example, the dinner is really the largest meal, you can certainly inject before the dinner. I think it can be done flexibly based on the patient's preferences.
Thank you, sir. Thank you.